Hi, everybody. Welcome to It's Worth a Shot. It's August 16th, and we are going to cover resident readmissions and provider collaboration today. Let's go ahead and go to the next slide. Here's just a couple of updates and reminders for you guys. We are still celebrating Immunization Awareness Month. Next week on August 23rd, during our It's Worth a Shot, we are going to talk about some immunization updates. Kyla Newland, one of our Mountain Pacific team members, is going to present on that. On August 30th, we are going to talk about adverse drug events. We're happy to have Jesse Kinsey join us again. On September 6th, we'll have the mobile vaccination clinics for fall season. And then September 12th, we have a presentation on the MDS updates. That will be a good one for you guys to hop on. We will send out the information for you guys to get registered for that. So keep an eye out for that. And then September 13th, we will be talking about enhanced barrier precautions. So some good upcoming presentations. So make sure you guys join us for that. Let's go ahead and go to our next slide, please. So as a reminder, we do the evaluation, so please make sure you guys add any topics that you would like us to cover. We keep a running list and try to make sure that we are addressing all of those. And then we'll remind you at the end again to make sure you guys fill out that evaluation. We really, truly appreciate your feedback. We just have a quick polling question for you guys. So the question is, are all your residents current for their pneumococcal vaccine? And I like that answer. Good question. I better check into that. Looks like you guys have a pretty good handle. Oh, there's a couple of you guys. Gonna look into that a little bit. Okay, give you another second. Okay, let's go ahead and end the poll. Looks like either no or it's a good question. We better check into that. So thanks for participating in that. We'll do some reminders on the pneumococcal next week. So, okay, let's go ahead and go to the next slide. So for our COVID-19 hospital admission levels, as you guys remember, a couple of weeks ago, we changed our graphic on this. This gives you a better picture of where our hotspots are. You can see for our region in Montana and Alaska and some of our islands in Hawaii here, there's a moderate increase or a substantial increase. So just some areas to watch for. Over the past week, there's been over 9,000 new cases. So some pretty significant COVID activity going on. Let's go ahead and go to the next one. And you can see that's a 12% increase in the past week for hospital admissions. Deaths, unfortunately, is starting to trend back upward. We were on a pretty steady decline for the summer, and now we've kind of spinning the curve on that one. And then vaccinations have increased a little bit more. I think a couple of weeks ago, we were about 146, and now we're at 152. So seeing some improvements there. Again, I know that we really emphasize planning for those fall clinics. So make sure you guys are having those conversations. We are working on updating the multi-vaccine consent form. So that will include RSV, and then we'll redistribute that to everyone. So as you guys are having those conversations, you can get your consent forms ready to roll for the fall. So let's go ahead and go to the next slide. And I would like to introduce Annie Whalett. She is from Riverside Health and Rehabilitation, and she is going to present on readmissions and provider collaboration. We'd like to welcome Annie today.
Hi, guys. I've been at Riverside for about 3 years now, but also spent 15 years as a discharge planner. So have been part of thousands of admissions over the years, and thought I could speak to some practices that might make things easier for everybody. So next slide, please. All right. So for Riverside, we currently have someone that assists us with getting some of the information in front of us for the referrals. I'm sure most of the facilities have an admissions coordinator or someone taking that information and getting that to our medical record system. What we have added on is to make sure the places we commonly get referrals for, we have access to their medical record systems. So that includes Epic and Cerner, which are across most of the western part of Montana. So instead of needing to go back and forth sometimes with those case managers we're receiving referrals from, we can go directly to their chart. We have found that getting into that access takes a few phone calls through the IT department, but it has been well worthwhile the effort, especially if you feel there's something that isn't being disclosed about a referral that you have coming in. And it also gives us the chance to not wait for a phone call and a fax to get information back. We can access those records immediately. Next slide. We've been working hard to minimize our recent readmissions. We know it's difficult on our residents. It is an outcome that's looked at both for the hospitals and the skilled nursing facilities. So we want to collaborate to minimize those. And there's been specific things we've changed as far as our reviews in collaboration on those admissions that we'll talk about. Next slide. So we tend to slow ourselves down mostly around the most complex cases that look like they may be on the edge of what we're able to do and have the time to do. Examples would be wound vacs, folks that might need frequent antibiotics or IVs, making sure all of our staff know how to run a tube feeding system from morning, day into NOC. And then if we are going to challenge ourselves with a new task, that we have our staff educated and training in place before they come in, so that improves our outcomes and also helps avoid rehospitalization because of staff not knowing exactly how to care for them. And then we also look at our staffing patterns to ensure within the acuity that's already happening that there's time to do those more complex tasks. Sometimes with these more complicated folks, Friday admissions need to be avoided. So the managers are here to support our staff on maybe some new tasks they might need to learn with those people, and make sure we have a guide by their side if there's any questions about how do we get them back and forth to dialysis? What happens if the tube feed gets kinked? Those type of things that can be handled on site with the supportive management during the day really helps our staff be more effective. Next slide. Sometimes we'll find that if we can plan ahead enough, if the referrals are in a timely manner, we can order the supplies we need. But those components can be overcome if we don't, by asking the referral source to send the supplies that they need until we can get those ordered up in a good time. And make sure you're working with your central supply people to know what we do have available versus not. Sometimes the facility won't have those. That's when it's important to know who your local DME providers are, durable medical equipment, the folks that would set up tube feeds in homes, IV antibiotics at homes, ostomy cares. They can be a good backup to loan or purchase those additional items until you can get them through your usual supply chain. So we just use that as a best practice and keep those relationships up with those folks that we're already referring to when people are leaving from us. Next slide. So we did find when we were looking at our readmissions that most of them would happen, or our discharges against medical advice discharges would happen on a Friday or a Saturday, that their first steps here were not well explained, or they didn't understand what they were getting to. They come from an environment in the hospital where it's clearly told to them, how things are going to go, when things are going to go next. And there's very little control, whereas most of the time in the nursing home settings, we are encouraging them to tell us how they would like it to go. So if we can get that care conference done of setting expectations, introducing your team within that 1 to 2 day window, we can improve their reassurance on who they can go to for assistance, put back into their hands and learn from them immediately what changes they need in services and how they would like to be supported. So we spend a little extra time in those meetings to make sure what's your first day's experience been like? Have you been surprised by anything? Do you enjoy the foods you've had so far? Are you bored? Do you need additional activities for your time here? Or what just might not be going well or causing you worry first thing? And all of that can be addressed by the interdisciplinary team in that first care conference and really smooth things out, as well as make them feel confident that they're going to get good care while they're here. Because most of the times the things that lead them to be needing rehab and skilled nursing were a tough situation, and they're still kind of getting over that and processing what's happened to them with that. Next slide. Sometimes our families will want to postpone. They have things going on during the weekends. And that's a good time to make sure that they already feel confident with the facility, or that they understand completely what that initial care conference can do, and encourage them to get that done sooner. Make sure you have staff available to offer and get that done during the weekend if it's a less complex case you've taken on a Friday. And also make sure you offer a conference call where they can call in if they physically can't be there instead of postponing. Another thing that really helps in that initial meeting is to talk about what they expect for their medications in case the reconciliation between hospital and the skilled nursing is not as accurate as they expected, or there were changes to their medicines while they were hospitalized they were not aware of. A lot of times it's just that they've come over in a different name under a different formulary, and make sure they understand what they're seeing for medicines that they're receiving, and there's no surprises within that or adjustments that they're asking for immediately. Next slide. So early collaboration for our anticipated admissions with our doctors gives us a chance to prepare the chart and speak with the provider that might be sending them over here, especially if we're looking at folks coming from facilities we're not used to taking, may it be Sacred Heart Medical Center, some of those higher level hospitals that may be out of our typical referral base. So we want to make sure our physicians have access to that chart information. They feel prepared to take care of them, and there's plenty of times for them to have questions and vet out what the expectations are from the sending provider for their rehab stay. And then if we have problems with our transfers, there's an issue with the case manager or the physician or reporting, our medical director is our best bet and first go-to to smooth out those transitions, especially if it's a provider to provider issue. And they've been very helpful in assisting educating the sending provider of best practices and why it creates a safer situation for the residents that are coming in, and ensuring that the medical course they anticipated is being followed through by the accepting facility. Next screen. So with these priorities, we have residents who have been more comfortable in directing their own cares and speaking their preferences immediately, helping them feel empowered. We know skilled nursing facilities can be scary to them. They can fear that they'll be stuck here. And when we put that empowerment back in their hands, it's a much more positive experience. And at the same time, we've been able to decrease our readmission rates, improve the outcomes for our residents in our care, and they feel confident. They know who to go to, when to go to, and that they are directing how their rehab stay should go and what it should look like when they're ready to leave. Next slide. All right. And those are so this is me. Again, I spent 15 years at the hospital. Oh, I see the question from Shay. Annie, are you seeing any benefit with coordinating with local providers? Yes, especially if we have folks that we're looking at coming in from home. Having those relationships with the physicians in our communities builds reassurance that we are going to take good care of their patients if they're no longer able to stay in the community or they need to come in here for a short rehab stay. So their case management teams feeling comfortable calling our admissions team and getting that communication is reassuring. And at times when we cannot take them, we'll even take the extra step and turn them on to the resources that might be able to help them as well. So it leaves a good feeling that even though we couldn't help them exactly, we still tried to help them with what they were needing and getting the resources in front of them they need. We do review readmissions and copy. We don't have a form. We're more looking at the percentages and making sure that we are hitting a company goal of, I think, less than 15% over a month's time. And we've been pretty good staying between 0 to 5% most consistently on most months. Any other?
Oh, sorry, go ahead.
No, just any other questions or things?
Yeah, sorry to keep bothering you. I
No,
think our listeners may benefit from a few things that I've identified just within my site visits. One thing that we're trying to kind of narrow down, if there's any common denominator with your readmissions, any common diagnoses that you have to pay attention to, anything like that you guys are aware of?
Our readmissions have been very low. I think the most common denominator would be our weekend admissions when we didn't have all the components exactly in place for their care or hadn't had the chance to explain expectations here so they could state what they were expecting to have for cares and get that put in place immediately has been our most consistent issue. And then just the complex medical cases, we need to slow down and be mindful if we've got multiple disease processes that we're trying to support and help get them rehab through.
Okay. And then also, Annie, when you, as we're looking at like the more rural nursing homes, I was just curious, is there anything that you would suggest for them, just because they are oftentimes not close to, I guess a major hospital or specialists. So is there anything that they can do to help prevent those readmissions?
I think it's knowing, asking maybe for a day or two further of stabilization. If they see something that they are concerned might backslide or get that person into more trouble. Of course, we're looking to make sure they've had bowel movements in the last 3 days. Their lab work is looking stabilized. Their vital signs are looking stable. Their participation in therapies hasn't been impacted by pain being out of control. Spending 1 to 2 extra days in the hospital, making sure those components are strong and consistent can really help ensure nothing else has come up that they weren't expecting, that it's not just a day that they were able to accept clear liquids, that they were able to eat physically for 2 full days before they were sent over, as an example.
That's very helpful. I think that's kind of what they're running into, is just making sure that they are ready to come to their facility. So we just want to make sure that, we're I guess letting the providers and the hospitals just know that that is something that they're going to take a look at and just be a little bit more picky with their admissions. Would you?
Right. And that we definitely want to take them, but it's in both of our interests to make sure this is a great transition and those components are very well taken care of.
Okay. Yeah. And then that's the other thing. I think a lot of hospitals, not to their, I guess, not speaking poorly to them, but it seems like a lot of the ailments that nursing home sees is after a week or so of admissions, and then they're kind of blindsided by that. So again, are you suggesting just to prolong that admission until
I just sometimes even I just need 1 day more, or I need to make sure that their H&H is not going to drop. any further, and that really that upward trajectory you see has started is sticking. And let's see another day of that. Let's see 2 more days of that, and then we'll be ready. And usually they understand those concerns. All right, Mercy, let me see that full question. How about tips, resources to families who feel the resident should be admitted? I think we start with our in-house provider to see what the concerns are, see if we can get something done here that is within our scope to assess and try to assess within the facility. But at the same time, also empower them that if you really don't feel it's safe, that we will move forward with getting them back to the hospital. But I think mostly with families, it's education of what all we can really do in a nursing home, that we do have these resources. We can pull lab work. We can have a chest x-ray done, and it doesn't require them going all the way back to the hospital and, you know, being set back maybe even in their rehab course.
Thanks, Annie.
Yeah, absolutely. Any more questions for me? All right, guys, thank you so much for this opportunity. It's always fun to share what you think you've learned along the way, and appreciate your good questions. Hope it helps.
All right. We have a few more minutes, so I'm going to go ahead and screen share, and I'm going to share with you guys a tool that we have. This is a nursing home rehospitalization risk assessment. Can you guys see that okay?
Yes, we can see it.
Okay, thanks, Miranda. So this is a really good tool to use if you're thinking that maybe this resident would be at risk for rehospitalization. So this gives you kind of a little checklist you can work through, you know, their length of stay, any chronic conditions that they may have. And then once you get down here, you add up all of the boxes checked. 5 or more boxes would indicate that the resident is at high risk for rehospitalization. So this is just a great resource for you guys to take a look at, and kind of supports what Annie was talking about, you know, maybe offering some alternatives. So anyways, this is available on our website. I know she went over the website. So this is under the nursing home side and under our care coordination resources. We have just a couple of minutes. Does anyone have any questions on the tool or anything else? Okay. All right. Well, we'll give you back a couple of minutes of your time. Again, don't forget to please take a minute and fill out the evaluation for us. Let us know any training needs that you guys may have or any requests you guys may have, and we'll try to address that in our upcoming webinars. And again, don't forget, next week we'll be talking about immunization to kind of wrap up our National Immunization Month. So Kyla will have some great information for us. So have a good day, everyone. Thank you.